DisasterReady.org is powered by Cornerstone On-Demand Learning Software. This is a free, easy-to-use online training resource that provides e-learning courses created to help prepare a growing community of more than 60,000 humanitarian aid workers for the challenges they face in the field. The goal of DisasterReady.org is simple: to increase the preparedness and effectiveness of humanitarian aid workers around the world by providing accessible, affordable, high-quality training. Designed by experts in staff development and humanitarian action, DisasterReady.org is the result of a collaborative, nonprofit effort between the Cornerstone On-Demand Foundation and leading aid agencies in the sector. A bit about our presenters today. Mitch Loeb is a health scientist and epidemiologist in the Office of Analysis and Epidemiology at the U.S. National Center for Health Statistics at the Centers for Disease Control and Prevention. In addition to his work in the USA, he has carried out epidemiologic research in Canada, Norway, and several developing countries in sub-Saharan Africa and Southeast Asia. He is currently concentrating on the analysis of disability data from various U.S. health surveys and continues his international commitment to the development of culturally comparable and reliable disability measures through his work with the Washington Group on Disability Services, or the WG. He routinely trains statisticians from national statistical offices around the world, as well as representatives from governmental and non-governmental organizations, in understanding and adapting the WG approach to disability measurement for use in their own national censuses and surveys. Pauline Thivillier is a program monitoring officer at Sightsavers in the UK and manages the data disaggregation pilot project since 2013. She has previously worked for the UNHCR and Minds Advisory Group. Pauline holds a master's degree in public international law from the University of Manchester and is currently based in the United Kingdom. Today's discussion will be moderated by Ricardo Pla Cordero, Technical Advisor for Inclusion and Humanitarian Action at Handicap International. Ricardo has an academic background in philology, physical therapy, and gender development. He's worked in development and humanitarian projects, both at field and coordination levels. As a result, his experience in disability data collection and analysis in humanitarian settings runs from direct enumeration to data reporting for advocacy purposes. Experience that has provided him with good understanding on the challenges for disability data collection in these kinds of contexts. I'll pass to you, Ricardo.
Thank you, Anna. So welcome everybody to this webinar on AIDS and disability data collection in humanitarian action. As Anna said, this is the second in a series of webinars delivered as part of the AIDS and Disability Capacity Program. The first webinar introduced the minimum standards for AIDS and disability inclusion in humanitarian action, and the recording is available in DisasterReady and YouTube. The purpose of this second session is to introduce AIDS and disability data collection in humanitarian action, something that is specifically recommended across the minimum standards that I just mentioned. Our speakers today will provide an overview of some of the existing approaches, tools, and experiences of AIDS and disability data collection in different contexts. Mitch Loeb will introduce the Washington Group of Questions and will also share some of its uses in different settings, and mentioning also recent studies of their use in humanitarian settings that you can also consult. And Pauline Thivillier will talk about experience of data collection in India and Tanzania, sharing challenges and lessons learned in this context. Finally, we will be taking some questions from the participants. But before starting, I would like to shortly introduce the AIDS and Disability Capacity Program. ADCAP is an initiative of the AIDS and Disability Consortium, a group of 7 agencies working to promote AIDS and disability-inclusive humanitarian assistance. The program is funded by the UK Department for International Development, DFID, and the United States Agency for International Development, USAID, and is led by HelpAge International. The aim of the program is to strengthen the capacity of humanitarian actors to deliver age and disability inclusive response. But coming back to the topic of today's discussion, I would like to start with a polling question. So, I need your participation here. Collecting data on older people and people with disabilities in humanitarian context is the responsibility of specialist agencies. Do you agree or disagree? You can use this icon to raise your hands. So hands up if you think that is mainly the responsibility of agencies like HI, CBM, or HelpAge. Can we have some answers there? Well, of course, it's the responsibility of all of us. There are times where technical support is required, but humanitarian needs assessments and reports could also reflect the needs of older people and people with disability if the international community commits to address the challenges that this process could entail. For this purpose, the minimum standards on age and disability inclusion recommends in the first key standard to systematically include people with disabilities and older people in data collection, registration, and all assessments, collecting sex, age, and disaggregated data, what is SADDD. This concept is introduced in this first standard, but you will find it highlighted in each of the sector-specific standards, together with many activities and reasons why to collect this SADDD. But also our speakers of today will share information about why it's important to collect this data. And I would like to share with you also one quote that I think is very, very expressive. To make people count, you have to count them right. This is from the WHO disability training on disability statistics that shares also many information on how this can be done, not specifically for humanitarian context, but for development context. But which are the approaches and tools that can be used? Well, HelpAge recommends for sex and age disaggregation the following age brackets that are displayed: 50 to 59, 60 to 69, 70 to 79, and 80 plus. But there are other resources that are included in an annex that I invite you all to review into the minimum standards. And also there are other resources that have been recently published, like the RAM-UP, the Rapid Assessment Method for Older People. And today we will have more knowledge about the Washington Group of Questions. So I would like to leave the floor to our first speaker, Mitch Loeb. Welcome, Mitch.
Thanks a lot, Ricardo. Yes, I now have the, I want to talk to you a little bit this morning about the Washington Group on Disability Statistics and how disability can be measured in a way that's comparable across countries, which is very important for international data collections. The Washington Group evolved out of a United Nations International Seminar on the Measurement of Disability way back in 2001. At that seminar, it was clear to the people who were present that there was no standard for collecting disability statistics, and the statistics that were collected were very often not comparable. Often from low-income countries, prevalence rates were less than 1%, while from high-income countries, prevalence rates were 10%, 15%, and over. So what happens in situations like this is that the United Nations Statistical Commission sets up a city group to address the need for population-based measures of disability in this case. They wanted to foster international cooperation in the area of health and disability statistics and produce internationally tested measures to monitor persons, the status of persons with disability. So we were formed, and as a city group, we're named after the first city where we meet. And the first meeting of this disability group was in Washington, D.C. And that's the only reason that it's called the Washington Group on Disability Statistics. Countries, on the other hand, have ownership of the group. These are representatives from national statistical offices around the world. And as of right now, there are about 133 countries that are represented in the Washington Group. All of them don't come to every meeting. All of them don't voice their opinions, but they are on our mailing list. They get information from us, and we share our information with them. There are also international organizations that represent persons with disability, NGOs, and international non-governmental organizations. We have a secretariat that's located where I work at the National Center for Health Statistics here in Washington, D.C., and a steering committee that oversees our work plan. But it's work groups made up of representatives from NSOs around the world who actually carry out the specific tasks that we have. Currently, we have a work group on child disability, the environment and participation, and analysis. But we have a strong emphasis on evidence and transparency. We test the questions that we develop extensively in multiple countries around the world. The Washington Group questions that I'm going to talk about were developed to collect internationally comparable disability data based on the social model of disability. That's as described in the International Classification of Functioning Disability and Health that was proposed by the WHO in 2001. Prior to that, disability measurement was centered on a medical model. What I say is that it focuses on a person's physiology. You could say what's wrong with them. Not that anything is wrong, but that's the kind of thing that you're looking for when you're asking those kinds of questions. Focused on medical models. Do you have a disability? What's your impairment? That kind of thing. Whereas with the social model, we're interested more in functioning in an accommodating environment. Disaggregating outcome data using the Washington Group questions would fulfill the monitoring requirements established by the UN Convention on the Rights of Persons with Disabilities and the post-2015 Sustainable Development Goals. The Washington Group tools, I'm going to talk a little bit about those now so you can see what we've developed. We've developed question sets that focus on measuring difficulty functioning in universal basic domains of functioning. The short set of questions was first adopted in 2006, and this is the short set of questions. This is what I'm going to be focusing on for the most part. They're simple and straightforward. Because of a health problem, do you have difficulty seeing even if wearing glasses? Do you have difficulty hearing even if using a hearing aid? Difficulty walking or climbing stairs? Difficulty remembering or concentrating? Difficulty with self-care, such as washing all over or dressing? And using your usual language, do you have difficulty communicating, for example, understanding or being understood by others? And each of these questions has 4 response categories: no difficulty, some difficulty, a lot of difficulty, and cannot do it all. So we move away from measuring disability as a dichotomy. Either you have it or you don't. Disability is very complex. We're focusing on functioning, difficulty doing some basic activities, and creating a kind of continuum of severity based on this response scale. We also have developed an extended set of questions for functioning. The short set is 6 questions. The extended set has more, closer to 25 questions that include other domains that couldn't be covered in simple short questions. Include upper body functioning, affect, which is anxiety and depression, pain and fatigue. And we also begin to look at these in assistive devices and aids to look at the environmental component of functioning. We're working closely with UNICEF to develop modules on child functioning, and we include some of the basic domains I've already mentioned, plus learning, behavior, attention, coping with change, and developing relationships. Those are being finally tested now and will be launched in March of this year. We're also focusing on looking at aspects of the environment and participation because disability isn't just about how you function, but it's about how you function in an environment that is either creating barriers or facilitators in order for you to participate in society. So we're working with UNICEF on an inclusive education module. We're working with ILO on the development of labor force survey modules and looking at other aspects of the environment and participation. But in order to turn these questions into data and statistics, the Washington Group questions, they fulfill two specific data needs. We can describe data as a continuum of functioning based on these graded responses to the 6 questions. No difficulty, some difficulty, a lot of difficulty, and unable to do it all at all. And we can define a cutoff or a set of cutoffs that can be agreed upon internationally in order to disaggregate outcome indicators, things like access to education and employment, by disability status. And I'm going to give you some examples of that. And this allows us to calculate prevalence rates and disaggregation. In order to disaggregate, there are some things that we need. We need a straightforward and simple way to identify persons with disability. Identify those who are at greater risk than the general population for limitations in participation. That's using the Washington Group short set of questions, and I'll show you how that can be done. And we also need, in addition to disaggregating by disability or identifying disability, we need to have indicators or outcome data, things like education, employment, income, healthcare access, from data collections that also include the disability identifier. So here's what that disaggregation might look like. These are data that come from the United States, from the National Health Interview Survey, and I could look at percent of people employed or percent of people with access to healthcare by disability status, whether they have or do not have a disability according to the Washington Group short set of questions. And you can see that people with disabilities are less likely to be employed and have less access to health care. If we're concerned about the UN Convention on the Rights of Persons with Disability, we'd like to see these bars more equal than different. We can also go a step further and look at gender and disability. So we can look at access to primary care physician and look at males and females separately and by disability status. And what's striking here is that that males and females both have less access to primary care physicians if they have a disability than if they don't. And the same with age. The older you are, the less access you have to primary health care physicians. But on top of that, if you have a disability, you're even less likely to have access to primary health care physicians. So we can use the Washington Group questions to create these kinds of dichotomies and look at outcome measures. We can disaggregate by disability status and add age and gender to that as well. I said that we can look at different levels of disability, and that's what these questions, these simple 6 questions, allow us to look at. We can look at different cutoffs. So at the bottom of this slide, if any one domain among those 6 is recorded as I'm unable to do it at all, we get a prevalence rate of 2.2%. If we add to that, so now we're looking at everybody who has a lot of difficulty or cannot do it all, the prevalence rate is closer to 10%. And this is the recommended cutoff that we suggest for internationally comparable data. And if we can even include people who have some difficulty on more than one domain, 20% is the prevalence rate, and on even a single domain, we're getting closer to 42%. So you can see that disability isn't a single thing, and it's not, it's a broad picture of the population. We want to be able to mainstream disability statistics. The short set of 6 questions can easily be added to any ongoing data collections. They can be used in any national or subnational survey, a health survey, a labor force survey, income and expenditure survey, DHS, that's demographic and health surveys. And once the addition of the short set becomes integrated into core statistical systems, disaggregating outcomes becomes routine. You can do it on a routine basis, on an annual basis, and then monitor progress over time. Applications of the Washington Group short set I said on national censuses, more and more countries are using these questions on their census to create countrywide disability prevalence estimates. On surveys, as I mentioned, general population, standard of living surveys, household income and expenditure surveys, et cetera. Clinical and administrative data can also be used to include Washington Group questions. And finally, in humanitarian settings. There aren't a lot of examples, but we have a few from researchers in Australia at the University of Sydney who've used the Washington Group short and extended set questions to look at refugees Syrian refugees in Jordan and refugees in Uganda. And they've successfully used these questions to identify persons with disabilities in these humanitarian settings. Unfortunately, I'm at home right now because of the weather conditions in Washington. I have those references at work, and I'd be happy to share them with you if you leave a message. But I think at this point, that's the end of my presentation, so I'll hand it on to Pauline. Thank you.
Hi, Pauline. Thanks so much for joining. I think you may still be on mute.
Can you hear me now?
Perfect, yes.
Excellent. Thank you. I was thanking Mitch for giving me the right. So I'm going to talk to you about Sightsavers pilot on data disaggregation by disability. So a bit about Sightsavers to start. So we are an NGO that was founded in 1950. And our vision is a world where no one is blind from available causes and where visually impaired people participate equally in society. So we work in the following things. So eye health, neglected tropical disease, education, and social inclusion. And in the last few years, there's been a really big emphasis on social inclusion, and we now have a social inclusion strategy. And the idea is really to mainstream social inclusion in every single project we do, especially eye health and NTD. So why disaggregating data by disabilities? So we really started this pilot because we wanted to understand whether people with disability were accessing our services. And we know access is a complex issue, so we wanted to understand what were the provider and user-side barriers. And the first step really was to measure access, to see if people with disability were using our services, at what rate, and how does that compare to people with no disability. And we also wanted to build evidence-based to inform our work, share with others, and maybe demonstrate the clear case for collecting data on disability. And the ultimate aim is to make Sightsavers Eye Health and NTD project more inclusive of people with disability. So we really started doing this about a year ago. So far, I'll be able to talk to you about the point number 1 and number 2 with this presentation. So how did we do it? So we used the Washington Group short set of questions that Mitch just talked about, and we integrated that into a routine data collection tool, and we integrated that with sex and age disaggregation, so it happens at the same time, so the registration, the disability question will be asked. And as it was a pilot, we really wanted to monitor the experience of people involved in the project. So we did a lot of interviews, focus group discussion, and also the quality of the data collected, so a lot of spot check. And the question really to evaluate the project was how can data disaggregated by disability be collected on a project level in a resource-efficient way that is useful to policy and decision maker. So we piloted the Washington Group short set of questions in 2 pilot projects that we chose 2 very different projects to be able to gather learning. So the first one is in India, in the city of Bhopal. So it's an eye health project in a very urban setting, so urban slums, and we collect data in 1 hospital and 4 vision centers. We used the Washington Group questionnaire that we had to translate in Hindi ourselves because there was no translation available. And we work with local community development organization and an eye health hospital. We have census available from 2011, and the data set at 2.1% is the prevalence of disability. However, the question is quite different, are you disabled, yes or no? And India uses a very legal and medical certification of disability that is linked to benefits. Our other pilot was in Africa, this time in Tanzania. It's a neglected tropical disease project. So that was looking at trachoma surgery camps that are set in very rural village in the area of Ruvuma in Tanzania. So this time we had the translation of the question available to us because it was using the census, apart from the communication question that was dropped off the census. And in that case, we work with the government, so the Ministry of Health, and the national definition of disability is very similar to the CRPD, so much more social. So that was the 2 pilots we selected. Sorry, I went a bit too fast. There we go. So I'm not going to talk to you about the process and what we've learned at Sightsavers from setting up this pilot, and then I'll share with you the experience we got from data collector through the interview and focus group discussion. So first of all, we've learned that it's really important to know the context before using that questionnaire in your project, because disability is a concept highly dependent on contextual and cultural factor. So appropriate sensitization and disability in the Washington Group is essential and key. We just need to make sure we're all talking about the same thing when we mean disability, and that varies from country to country. There are negative attitude and stigma around disability that can prevent people from answering questions or lead to prejudice in those asking the question. In India, some patients were really offended about being asked a question about their health. In Tanzania, we had some data collectors that found it difficult to record what the patient was telling them, but wanted to assert their own judgment on the level of functioning of the person. We also have to be aware that asking questions can sometimes raise expectation when you start asking people about their health. Sometimes they expect some treatment or maybe some information, so it's important to think about what information we can provide, what are the structures available, think about referral mechanism, or just explain really clearly the purpose of this questionnaire. We also know that it's important to plan ahead and be very flexible. We also know that data systems can be resistant to change, and it's important to plan ahead the tool. So it's important to think about the translation of the Washington Group. It's been translated in quite a few languages, but it's not always available. Your tool is a paper-based data collection tool. In that case, it can be a bit difficult to adapt compared to electronic tool. The location of the data collection, where you collect that data, is important. We find that it's easier to collect in India in a quiet vision center in the slum than in a very busy public hospital reception where there's a lot of people in and out and already a lot of delay and waiting. And it's important to review the approach based on feedback from the data collectors, from the project manager that are implementing this and can see the difficulties. It's also important to ensure the buying and ownership of all the stakeholders around, and it's kind of also linked to that stigma around disability, explain to people why we're doing this, why it's important. Sensitization, therefore, should not be limited to only the data collector and project manager. It's important to sensitize wider. In India, for example, we had trouble starting this data collection in the hospital because we did talk to the project manager and key people that were going to collect that data, but didn't talk to the trustees, so it took a bit longer to implement. It's important to adapt the training session also to the local context, the local definition, and the census data is available to kind of trying to link it back to what we're doing in this context. And also it's important to ensure people have the skill to analyze that data. We ask them to collect data. They need to be able to analyze it and understand what it's telling them. So now I'm going to talk to you about the feedback we got on the questionnaire and on the process from our data collector and project manager. So on the Washington Group questionnaire, we had difficulty with question 1 and 2, which are the seeing and hearing question in Hindi. We had to review a translation quite a bit. We tried to break down the question in 2. It didn't really work, so that required a bit more work. In Tanzania, the references to hearing aid and climbing safe were confusing. In small villages, the concept of hearing aid or even steps wasn't there, so again, we had to adapt it. Questions 5 and 6 on self-care and communication cause issue as well. Some clients look really bored by this point of answering question. Some reports finding the question offensive, asking someone if they can dress or wash all over wasn't always well received. Similarly, the communication question being last kind of confused people as they've been exchanging with the data collector during the question before. And also some clients answer no difficulty repeatedly and very quickly just to get it over with. So with that feedback, we decided to conduct an analysis to see if that would affect our results. And when we removed question 5 and 6 of our analysis, it didn't show any significant difference in the data collected in terms of number of people with disability identified. So now we need to look at it, is it the question or is it these people are not accessing our services? So it's something we definitely need to look into. A question that comes up a lot when I do this is how long does it take and what's the workload? Data collectors already ask a lot of questions, it takes a lot of time. Do we have the capacity to do this? So we found that it takes an average 5 minutes to ask the questionnaire in the setting we did it in, so at registration stage. And we also find that all the data collectors report that it gets quicker with practice when they stop having to read it on their paper all the time. They just get better at it. So quicker, and that also shows in this project the quality of the data gets better with time. Obviously, this is dependent on some factors like the age of the patient, the language, is there any disability, do you need a proxy, so that can take longer. And again, clear introduction of the questionnaire avoids questions during the questionnaire, so it's really important to set the scene to avoid further questions. One of the very interesting findings we had is that we found that the process of engaging in the data collection had in itself a transformative effect. So just by collecting that data and being sensitized at the start, data collector reported giving special attention with people with disability and wanting to do more, wanting to give them information about where they can get services, introducing referral system. Project manager also reported looking at the data and thinking, people are not accessing, what else can I do? So they started changing the community awareness raising to include disability. You also changed patients a bit, in the sense that they're now asking for treatment information because they are disclosing some health difficulties. So in India, they started introducing referral mechanisms to the health structure, and in Tanzania, also starting to do referral, but also starting to provide additional treatment that people are reporting difficulty in the same problem, so they started to adapt the service delivery. I'm now going to talk to you a bit about the data we collected. So I'm going to talk to you about a sample of 16,000 patients in India, and we collected that data during the 10 first months of this pilot. And if we looked, first of all, at the prevalence of disability according to the definition of disability. So we used, first of all, the Washington Group cutoff, and we found that 15% of project clients coming to our services in India reported severe or completely limiting difficulty in at least one domain. However, we know that we provide eye care services, so we decided to remove the data from question 1. But we still found that we had 7% of people with disability accessing our services. And India, having the are you disabled, yes or no question in the census, we also decided to collect that data at the end of the Washington Group questionnaire. And when we compared that data, we found that 0.7% of people, when asked directly, are you disabled, yes or no, report yes, being disabled, which is quite a substantial difference. We also looked at our data and triangulated it with other data. So we look at location, and we find that the level of access at the hospital for people with disability was much lower than in the vision center, kind of implying there might be more barriers. We also looked at it with sex data. So we find that men are more likely to report a disability at the hospital than women, and we also find that women are more likely to respond positive to the Washington Group questionnaire than to the census question, whereas men would be more likely to respond yes, I have a disability to the census question and the Washington Group questionnaire. Finally, we look at this data with age, and we found that disability generally increases with age. So lessons for replication. So we found that disaggregation requires commitment to include people with disability, and it's fundamentally just the start of a change to inclusive services. It shows you where the barriers are, and it kind of creates that demand and the need to address them, so it stimulates the demand to provide them. And we found it's very important to ensure that the data will be used by people with power to implement change. So what's next for Sightsavers? So we decided to turn the India data pilot into an inclusive iHealth pilot, so using the data, the awareness and demand that we created to look at how can we make that project completely inclusive, focusing on gender and disability. So that's going to include accessibility audits, communication, mobilization. We're going to work with disabled people organization, blind people organization, and formalize those referral mechanisms that have been introduced. In Tanzania, we finished the pilot a bit later, so we're still analyzing there. But we're looking at something similar. In addition to a TT camp, what else can we provide to be inclusive? And we're finally starting a new pilot in Ghana in 2016. And this time the focus is different. Instead of measuring people accessing our services from a facility point of view, we're going to work on mass drug administration, so community volunteers going into the community to distribute drugs. And we're going to be looking at using, again, the Washington Group short set of questions in that setting, and also using the learning we've gathered in the other two pilots to see what else we can get. So that's it for me. We have a website where you can find all our reports and articles on this project, which is sightsaver.org. Everybody counts. Thank you very much.
Thank you, Pauline. So we are going to be taking now some questions. The chat is open. So if you would like to post a question, we will be answering to them. But I would like to start with a question on training, also to start the discussion and the reflection about this. You've been saying that enumerators would be needing training, and what kind of training it would be needed, and how long it would take to have this training done. Maybe we can have an answer from Mitch and from Pauline, as different contexts have been the question have been used in different contexts. Mitch, what do you say about that?
Sure. Thanks, Ricardo. I've done a lot of training internationally with enumerators and data collectors to get them familiar with the Washington Group questions, and it's not a difficult task really. You have to be able to set aside a few days to go through understanding what disability is and how it's going to be measured, because people have their own preconceived notions on how disability is reflected in populations. And we have to change their mindset a little bit to get them thinking now, we're not going to be looking at persons' impairments. What I say when I do my training, what's wrong with them. We don't look at that. We look at what people might need, how they're able to function in society. And that takes a little time to be able to get them used to understanding a different concept of disability, and then using these questions to collect that information. Pauline mentioned that in her work, they took an average of 5 minutes to deliver. In a lot of the work that I've done and seen, it takes less time, but it does depend on language, on age, on disability. Those all come into play, but it's not a very complex module to include into a data collection tool. So the barriers to using this are not insurmountable by any means. But a couple of days of training is what we usually count on. Thanks.
I really agree with Mitch when he said about the sensitization and changing people's mindset. We also find that was the first thing to do and very important to start the training with. I would agree also that it's not too hard to train people in the module. It's fairly straightforward. I think what we realized was needed was a bit of practice at the end. So include kind of in that training like an afternoon or maybe a few hours so people can maybe go in the community and practice or just ask each other questions so that they can become like familiar with the Washington questionnaire. And that also triggers some questions. They realize maybe they haven't understood something. They have some questions. So that's something we found very, very useful. But I would agree the key for me is probably the sensitization around disability, and then people are much more open to receive the tool.
Thank you, Pauline and Mitch. There's already questions coming in, and I would like to start with asking from Kirsten if there's any suggestion for emergency context where it may be a challenge to ask the full short question set, as is considered as too long for some people. What do you suggest here?
Let me try to answer that. We don't have a lot of experience in emergency settings, but we've had some discussions with people both in Australia and in the UK who are interested in, and Handicap International, who are interested in developing programs and projects to collect information in emergency settings. And from what I understand, I mean, if you think of the recent earthquake in Nepal, what needs to be done immediately is to provide services for people who really need them, to provide food, to provide water, to provide shelter. And going in and asking any questions can be a huge undertaking. If you want to have some idea of the scope of disability in emergency settings, there are ways to do that that aren't intrusive. You can, for example, take a random sample of people who are coming for food assistance or aid assistance. Take a random sample and ask quickly these 6 questions. If 6 questions are too many, and I encourage you to take them and try them, I think you'll see that it's not too much to ask. But if 6 is beyond the scope of what you're able to do, then we would, as seen in Pauline's presentation, rely on the first 4 questions. The first 4 questions give you most of the information that you need. 6 is ideal, but those 4 is, they're considered as core questions. So, so we see this as a real possibility.
Yeah, I would agree with that. We found that in a hospital setting, which is really busy, maybe 6 questions might be too much, so we're thinking about only 4. I think the other thing Mitch also mentioned, it doesn't necessarily have to be routine data collection. We did collect data collection like every single person coming to our services, so it doesn't have to be the case. And we're also thinking of piloting other methodology and can maybe sampling and see what we get. And also I think the other point to think about is where you collect that data. You have to be very careful about the point of data collection. So, for example, is it the registration the best place? Is there another point where maybe it is less resource intensive and costly? So I think that's what I mean by the planning. You really have to think about your process and where the best place to collect that data is to avoid creating further delay.
Thank you. Again, questions are coming in, and there's one related to this issue, and it's, well, Gregory is asking that in emergency context, baselines and assessment sometimes do not collect information directly from informants, but use proxies. Would be likely to, or or possible to use these questions using other people, but not directly people who or has the difficulties? What do you respond to this?
Thanks, Ricardo. Yeah, in many survey and census data collection settings, we rely on proxies to collect the information that we need. It's not always possible to go to everybody in a household and ask every question. So in a census, it's the person who answers the door who gets to answer the questions. In the children's module, for example, we rely on the mother or the primary caregiver, the person who knows the child best, to provide answers. So yes, somebody who knows the family, somebody who is responsible can answer these questions. The important thing to remember is that we don't collect information by observation. Never. We don't look at somebody and assume that they have a disability or a difficulty or anything like that. We base our assessments on the responses to these questions. So we have to ask the questions in order to get the good data that we need. Thanks.
Yeah, and in a similar way, at Sightsavers, we did rely on community volunteers. In Tanzania, when the camps were happening and people weren't coming, we usually have community volunteers or community leader pointing out where people might be in greater need, and then we were focusing, therefore, on outreach on those people, and then going there and asking the question directly to them. So that's also another way, I think.
Thank you. And Mitch, I think this is linked with one of the questions also. If there is a possibility for the interviewers to decipher some of the answers provided, if they have possibilities if there are ways also to prevent, if not people interpreting by themselves the answers.
Yeah, I understand the question, and actually the only way to really prevent that is through good training. When you do a survey, you may be training tens or even 100 enumerators to go out into the field. And there's a risk that you take there because every enumerator is different. Every enumerator brings their own personal experiences with them, even when they're asking questions, in the way that they meet people, address people, interact with people. So we have to put a lot of emphasis on training in order to avoid those kinds of situations. We don't want individuals to interpret through observation, and we don't want them to translate or explain in their own way what questions might mean. We put a lot of emphasis on translation so that we come up with a set of questions that is meaningful to the people who are being asked. That's not just a language, but it's contextual as well, as far as the culture and the country are concerned. So through good training and good translation, we should be able to meet the people who are being interviewed in a way that they're best able to answer these questions. Thanks.
Yeah, I completely agree with that. It's all about the training. And to build on that, we've trained different people in terms, we've trained community volunteers, we've trained young graduates in India, and we train medical staff in Tanzania, and each have their own understanding of disability. And so the training really needs to be adapted to the person you train. Like, we find it especially difficult with doctors, obviously, due to the medical training and medical background, the kind of idea to assess and put their judgment. So that requires a bit more work with medical staff. But yeah, I think the training needs to be tailored to your audience to make sure they get the message.
Thank you. And one question for you, Pauline. The enumerators were identifying people, but also to access services, right? So they were the identification was linked with admission criteria for the services.
No. So they were people that were doing the registration in Vision Center at the hospital. So they were admin staff at the hospital or Vision Center. So they were taking all the relevant detail and contact detail information, including those disability questions. So that was really the point when you go to services, when you do your registration, that's at that point that we train. So we train admin staff on this.
So then the users of your services were identified through other kind of questions? Like
they were.
For the eye surgery, they were identified through other questions?
Yes, so then they were moving on and going to see an ophthalmologist that will deal with the eye condition and kind of diagnosis part of it. There was no diagnosis being done. It was just purely to measure access. However, providing eye services, we kind of knew more people would come from eye condition. That's where we removed this from analysis. But no, the diagnosis part was done after, not at the point of registration. That was purely an admin exercise. Thank you.
And one question for you, Mitch, about this identifying by the enumerators, trying to identify. Someone, Gordon, is asking about if the Washington group can be used to include the so-called invisible disabilities, for example, involving mental health.
Yeah, no, that's a really, really good question. If you look at the 6 questions that I presented, you can see that they only cover 6 areas of functioning: seeing, hearing, walking, communication, cognition, and self-care. There's nothing there about mental health, psychosocial difficulties, or learning difficulties, and there are reasons for that. We didn't purposefully exclude them, but when the Washington group started to set out the development of these questions, the rule was that we could only ask 1 question per domain of functioning, and mental health, psychosocial, learning could not be captured in a single question. So we had to add those domains to the extended set of questions. Now, that said, we don't exclude those individuals from our measurement because many people, not all, but many people who have difficulty with psychosocial functioning or learning may also have difficulty communicating. They may also have difficulty with cognition, which is remembering and concentrating. So some, if not most of them, will be captured through these questions. The thing to remember, though, is that we don't use these questions to identify people by their disability type. In African countries, in many African countries, we get asked, what about albinism? People who have albinism. We don't have a question about that. And in many African cultures, having albinism is a disability. I understand that, but we don't have that particular question. However, many people who have albinism also have difficulty seeing. So through that question, we'll find many of them. We won't be able to identify them, but they won't be excluded because there isn't a question about them. The same goes with things like ADHD, attention deficit hyperactivity disorder. There isn't anything about that, but through other domains of functioning, because we don't live in isolation, but a lot of our functioning happens in a coordinated or interactive manner. I hope that answers the question. Thanks.
Yes, thank you. And we are running out of time, but there are so many interesting questions. One about data management. Well, how do we, which kind of software do we use to analyze data, and can it be shared through humanitarian exchange language, through platforms where sharing data for better responses and data collection worldwide?
If I can just quickly, we have the ability to share our data analysis tools with everybody. I do all of my data analysis using SPSS, and I can provide syntax to anybody who's interested in getting some assistance in analyzing the data. So that's what I can provide, what the Washington Group can provide.
And in terms of analysis, we developed, because obviously you also take into account when you do program the level of analytic skills that your data collector and program managers have. So we developed a very simple Excel spreadsheet that by entering the data in that spreadsheet using a pivot table, it kind of gives you a very basic analysis. We carried a more in-depth analysis here at headquarters using Stata, so a very similar analytical tool.
Thank you. That's very, very practical. And there is Carmen asking, what happens when we do not have the capacity to collect data and we rely on secondary data that has been collected previously? What can we choose to be sure that we have something reliable? Do you have any advice there?
That's a tough problem. If you have only secondary data, the thing that's important is to understand where those data come from, how they were collected, what questions were asked, because any data, even the Washington Group questions, have limitations. If you know what the limitations are, then you can get a better idea of what you might be missing in your data collection. We can provide you with some, we're beginning to get sort of standard data from countries around the world so that you'll know whether or not what you're getting is in the ballpark of what might be considered reliable data. Just be careful with secondary data. Try to understand how it was collected and what limitations there might be.
Yes, and we had a really good example of that in Tanzania, where they told us they used the Washington Group questionnaire for the census, and we thought we would be able to compare data with that. However, when we looked at it closely, they did insert, before the Washington Group questionnaire, the next questionnaire about disability, which completely kind of messed up the results and the comparability. So that's exactly what Mitch said. You need to be careful about how it's been collected and the methodology behind it to make sure it's comparable.
Well, thank you, everybody. This invites all the attendants and all the humanitarian actors to start using this data. So secondary data used in the future will be reliable and comparable if using this Washington set of questions. Well, we are running out of time. We displayed some resources for your support, but you have also our emails and our contacts there. So please do not hesitate of contacting us. Thank you, Michelle. Thank you, Pauline, for your time and your experience sharing.